Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy, I'm a nutritional therapy practitioner. I'm joined today, as always, by Dr. Jason Martin, very on the nose. Dr. Jason Martin, he's a board-certified
very much on the nose, Amy.
Plastic and reconstructive surgeon. Dr. Martin, how you doing?
Good, I'm doing very good.
Good. We have a very exciting topic today. We're talking about
one of my favorite topics. This is put that out there now.
Rhinoplasty.
Yeah, your perfect rhinoplasty.
We have 2 other episodes on rhinoplasty, which you can actually find now in the really awesome YouTube podcast
Nils is going to show them
section.
right here. Last episode, I didn't require Nils to do a lot of editing, but now I'm the...
I wasn't talking about in the links below. I was talking about on YouTube. If you're watching this podcast, you can actually find all of our podcasts under the podcast tab. So rather than having to search through all of the episode or the videos on our channel, which is Jason Martin MD, you can go to Jason Martin MD, look on the podcast tab, and see all of our podcast episodes listed there.
Right.
We have... Well, let's talk about rhinoplasty. And I think we have rhinoplasty 2.0. And now we have your perfect rhinoplasty.
It just keeps getting better.
We keep refining it like a rhinoplasty should be refined.
So I listen to podcasts while playing it on YouTube, which is, I know, odd. And so the problem is that you have to play it and then you put it in your pocket, but it's still playing and sometimes it'll get disrupted.
You mean the video, like the
video.
Screen is still playing.
Yeah, the screen is still playing. And that's probably not good for your battery life. So it's my understanding, right, Nils, now that on the podcast section, you can, or actually you would have to have a different app for that.
You have to do the YouTube Music.
YouTube Music.
Okay, so YouTube Music app,
It aggregates them from our channel.
Exactly.
So it's all the same stuff.
If you don't listen to it on Apple Podcast or what would be some other ones that you would
Spotify
for
Podcast
sure.
Republica, Stitcher.
Then you could actually listen to it on YouTube Music.
Yeah,
and without having
you don't have to have your screen on. So you can actually listen to podcasts on YouTube now like regular podcasts. Like not a YouTube video, like a podcast.
So crazy.
Yes. Podcasts are still a thing, clearly. All right. So,
but I listen to podcasts and also watch the YouTube videos. I do that. Is that a normal thing, Nils?
I do both.
Actually, the number one aggregate of podcasts is now YouTube by 27%.
Great.
Over Spotify.
I like that. I'll listen to it, on the podcast app. Or then I'll watch the YouTube, and it's mix and match sometimes. Yeah.
All right. So as we do with all of the episodes about surgeries, we start out with the stats. See, Sarah even put stats instead of statistics, so I wouldn't have to say
because when you get past one syllable for you, you struggle. You're on the struggle bus. So stats. Thank you, Sarah.
Yes. So these are still from 2020. Even though we're in 2023 now, we have not gotten the updated numbers yet. We should be getting those actually pretty soon. But rhinoplasty in general is a very popular procedure.
Very popular.
Even in 2020, there were still over 350,000 rhinoplasties performed, and that was only a 3% decrease from the year before, which if you watch some of our other videos recently, you see that sometimes that drop from 2019 to 2020 was pretty huge for unknown reasons. But rhinoplasty stayed about the same. What
happened in the world? Yes. I don't know.
It's a mystery.
It's a mystery.
Yeah. But overall, the gender distribution for rhinoplasty does, as with most of these procedures, tend to lean more toward women or females. So in 2020, there were about 287,000 women who had this procedure and 65,000 men. But it is definitely, for us at least, one of the more common procedures that we do for men is a rhinoplasty. Like it is really a awesome surgery for anyone. And we'll kind of talk about the specifics of why. But the breakdown is what you kind of would expect to see. Highest percentage of people getting rhinoplasties are those young, right? Just over 20. So 20 to 30 is your biggest amount of people. Goes up, goes down a little bit in the up to 40 range. 40 to 50 still stays pretty high, and we actually do a lot of rhinoplasties in that 40 to 50 range.
So we'll do a lot of them with the face and neck lift. We'll do a rhinoplasty also.
Or people who get a face and neck lift and they're like, my nose has always bothered me.
Why not take care of it?
Yes. Yeah. When they realize how awesome a facelift is, they're like, ooh, maybe. I mean, we've had a number actually in the last year of patients who have had a facelift and then within 6 months do a rhinoplasty.
Right.
Because they realize like, wow, this was awesome. Like, what else can I fix?
What else can I fix?
Yeah.
So our male patients, at least in our practice, anecdotally speaking, are the ones who usually have most post-traumatic kind of rhinoplasties. They have injuries that cause them to have deformities on their nose.
Which we will talk about.
Yeah. Females in our practice, they're younger. They have congenital problems with the nose. They're born with bumps on the nose, a prominent tip, et cetera, et cetera.
Yeah. So rhinoplasties are very common. I mean, I think this is probably more, and this is just with plastic surgeons. This doesn't include ENTs or anybody else.
ENT is a big part of this. It's a street battle, obviously, the facial plastic surgeons and the plastic surgeons, but I think they're both equally competent to do these kind of surgeries.
This is where I would like the Anchorman clip to come in.
Oh, we don't have the rights to that
right?
one. Yeah.
Maybe it's a really short clip like we did with Fight Club.
Yeah.
Like brick.
5 seconds.
You had a trident.
Yeah.
Yeah, very common in men and women.
Yeah.
And that doesn't include the street battle with ENTs.
Yeah.
Yeah. All right. So let's talk about The magic of rhinoplasty, as we've said many times, is that it is a surgery of millimeters.
Yeah, get a ruler out. Look at centimeters and then look at millimeters. It's not a lot. And in surgeries where you're dealing with small proportions, small measurements, you better be sure that you're going to someone who's an expert that feels very comfortable with these surgeries. There's not a lot of leeway. You can't take out more than a couple millimeters too much, and then you really know it, and there's a problem. So this is a very finesse, localized surgery that has amazing outcomes, but you don't have a lot of opportunity for error.
Yeah, not a lot of leeway. And that's what I say. Small changes make a big difference.
Yeah.
We talk about the nose. We'll talk a lot about the internal workings of the nose, but it's very much like a tent.
Yeah.
If you make if you lose one tent stake, your entire tent is now wonky. So oddities on the nose are easily spotted and may be quirky or just weird.
Yeah.
So you might have a cute, quirky nose, or it's something that people look at you and are like, wow, that's off. Unfortunately, the nose is something we do look at on people.
Yeah.
We look at the eyes, but we definitely see the nose.
Oh, we definitely do.
So it's not one of those things that you can hide. And that's why I think people are a little trepidatious to
and
do.
it has that little gestalt for the nose, because sometimes noses are disproportionate to the face, but they actually look good.
Yeah,
and
that's the quirky.
Yeah, and sometimes they don't. Owen Wilson
I
is
don't
a good
like
example.
his nose.
Well, it's fine.
He's not my speed.
But that's fine.
Yeah.
I didn't ask you what your preference was.
I was also like, who's that? Oh gosh, he was another famous actor. He died recently who had a really odd nose. I can't think of his name. Wow, this is
That's
really
like
great
a lot of
television,
people.
right?
Yeah, there's a lot of actors with weird noses. But so, it doesn't mean just because you have weird proportions or it's different than your face that it won't look good.
Gerard Depardieu, was that he the weird
Totally,
nose?
like that, 100%.
Yeah. And no one wants an obvious nose job, right?
I misspoke. I said there's not a lot of opportunity for error. What I meant to say, there's a lot of opportunity for error with a rhinoplasty, but that's why it makes it so difficult. Every step you can do wrong. And so it's very important that you get into this mindset when you do these surgeries of trying to get as close to perfect as possible.
Yeah, absolutely. I mean, like I said, no one wants that obvious nose job.
A millimeter when you're doing a tummy tuck is one thing. A millimeter when you're doing a rhinoplasty is totally different.
Exactly. Yes. So what are, Dr. Martin, the types of rhinoplasties? You mentioned traumatic, post-traumatic rhinoplasty, which is one.
Yeah. So there's actually another one we don't have on here, but this is good. So you have open or closed. So if you look on the internet or you look on our YouTube channel, we'll probably show you some pictures. An opened...
we have pictures at the end of this episode
Great.
as well.
So an open rhinoplasty makes an incision on your columella. How would you describe that in layperson terms?
Well, we're going to talk about the anatomy.
Okay.
Yeah.
But it makes an incision. It opens everything up. It opens the cartilages on the tip of your nose, and then the cartilage in the middle of your nose, and the bones that are above that. A close uses incision inside the nose and really does expose the cartilages in the middle of your nose and the bone above, but not the tip itself. So that's the difference. Theoretically speaking, a close is less traumatic and doesn't have a visible scar. So, but FYI, just like everything else in plastic surgery, people try to market it. I only do close, I only do open, which is complete.
You should only do the one you need.
Yeah, it's you need what you need,
Yep.
and you have to go to an expert, and they can tell you, oh yeah, you're a good candidate for a closed or good candidate for an open. Secondly, is what we call like just tip work. Okay, and you could do that open or closed, but that's affecting the tip and not dealing with the dorsum or the bridge of the nose as much. Third is post-traumatic, which encompasses a lot of
You
different
skipped
things.
over
What?
Alar.
Oh,
Or
sorry.
the Weir excision.
Yeah, Weir excision. There's number two would be a lot of different options that are less invasive. A Weir excision is where you affect the wings of your nose or the airways, making the ala smaller.
And that's really external only.
Right. And so those are the other procedures, and a lot of those you can actually just do in the office under local anesthesia. Third is post-traumatic. We see a lot of those, especially in Colorado. You see it with sports. You see it with outdoor activities.
You see it with fights.
Those are usually
Noses break people.
Fracturing of the nose, and we'll talk about the different sections of the nose and the anatomy. And then the fourth, I think which is technically a rhinoplasty, but it's really not. It's a septoplasty and turbinectomy is dealing with the airways. And for sure, some plastic surgeons do that, but that's more likely an ENT surgeon that does airway surgery.
Yep. Or combo. That's why we can do those at the same time.
The fifth one, which is not on here, but this definitely getting more common, is anatomy sparing rhinoplasties. We're not going to go into that too much today. Maybe we'll do a separate episode on that. It's kind of interesting, is where you preserve the anatomy, but you just change its location. So that's the bridge of the nose, the bone, and the cartilage is there. You make these kind of osteotomies and
Well, that's still done through either a closed or
open or closed.
approach.
Yeah. But
Like-
it's now it's been a carve out. So people are searching out surgeons that do these types of surgeries, anatomy sparing. But again, just like an open and closed, the same conversation. Everyone's not a candidate for this. And that's the problem, is that people get into selling these surgeries and they're not really telling you that you may not be a candidate for that.
Right.
So yeah, but open and closed would be the big question that when people come in, or can I get away with some of these smaller procedures? TIP, ALER, full. Post-traumatic can use an open or closed approach, and airway work, again, is going to be most likely with an ENT surgeon.
Yeah. So there's a lot of approaches, but I think with all of the surgeries we talk about, people very much get caught up on the terminology. And the type of rhinoplasty you need is the type of rhinoplasty you need to get the outcome you desire.
Right.
And a small incision at the base of your nose, we're going to show that here in a moment with pictures, is not visible. It's going to heal. Like if so getting the right surgery to fix the problem that's bothering you is far more important than the terminology around it.
Sometimes I feel like when you tell people, like, the surgery you need is the surgery you need, they get frustrated because,
Like,
no, I want this.
The magic surgery.
And the reason we do this podcast is literally so you're educated when you go into that appointment and they tell you what surgery you need, then you know that, hey, this sounds correct to me. I understand what they're saying. I'm empowered. That's the point. It is cool. Rhinoplasty is really interesting. It's such an interesting surgery because of
the
complexity and the different things we can do. It's almost like a chess match. I move the pawn here and I move the queen there, that kind of thing. And rhinoplasty has that kind of nuance, which I love. I love that, but it does make it more complicated. But if you come in and say, I want to close, and you're definitely a candidate for an open, I don't know what to tell you.
Right. If you need end fracturing and you want closed rhinoplasty, well, then
Yeah.
What you should want is the result, and the way to get there.
Exactly. Right. No, but exactly. No, but like, that's good. Like, you come in with an idea in your head, like, I want my tip more refined or smaller.
I want to get rid of this bump.
Bump on my nose. I would like my nose narrower. Narrower.
That is a word. Narrower.
Okay.
Narrower.
Doesn't sound like
I know. It's one
It
of those
doesn't sound like a
things.
word.
Narrower.
Narrower.
I
This is
never.
yeah.
I never.
Amy's speech pathology has infected all of us now. Nils.
Yeah,
And
we've
before
all
you
got
know,
it.
Sarah
Yeah.
will be infected. All right, next one.
We've all got it. So let's talk about the anatomy of the nose because it is so specific. And I asked Dr. Warren to do some sketches, and what he came back with was far exceeded my expectations. So if you are listening on any of the many apps that let you listen to podcasts, I highly recommend going to YouTube and finding the video of this podcast because these pictures are remarkable and they really do show all the different parts of the nose and why this is such a chess match.
they're
Yeah.
awesome. Awesome.
Yeah. So you know what's really funny about art is you can be a really good artist and there's someone out there way better than you.
Well, that's just life.
I don't know if surgery
You can be
has
really
that.
good at
I don't
anything.
think surgery has that because surgery is so subjective, but art is subjective too, but you can see someone's talent. Like, I've always been able to sketch really well. And obviously that translated over into my career very much. I'm really appreciative of that. But it is interesting to see some artwork when you're looking at it, and it's amazing. It just blows your mind away of the talent that people have. So I like to sketch. I'm not sure people like that anymore now that AI is doing all this for us. But if you look at the anatomy of the nose, so Amy, we're talking about the superficial anatomy, right?
Correct.
The first layer would be skin.
Yep.
Everyone has skin under their nose, and we know that.
Hopefully.
Yeah. Well, hopefully they do.
Yeah.
We know that because people's skin is different on the nose. You think about Bill Clinton, he has a phimotic nose. It's kind of thick skin and kind of irregular. You have real thin skin on noses. You've seen those are usually more Western European types. You have people that have wrinkles on their nose and discoloration and different color skin. So skin is the first layer. You're not going to change that much. You can do lasering. You can do some other treatments, but really it is what it is. Now, the thicker the skin, it's sometimes beneficial because it can hide deformities underneath. But sometimes that can work against you with the rhinoplasty. The thinner the skin, you definitely see things. So you see people with real thin skin on their nose. You can almost see the cartilage through the skin, which is really interesting, right? And if their cartilage is misplaced or prominent, then they don't like how that looks. We have a case like that coming up. So the nose is divided into thirds. We'll show this later on, but the upper
We'll
third.
show this right now.
Ah, look at this. The magic of computers. The upper third is, now I see why you want to use it.
See?
Yeah, so smart.
That's why I wanted both of
Yeah,
them.
the upper third is bone, and that's
That's
consistent.
the like light gray at the top.
Yeah, if you're looking at our YouTube channel, the middle third is the upper lateral cartilages. which also includes the septum, which is the temple that holds up the nose. And the lower third is the lower lateral cartilages, which represents your tip of your nose, and also the ala, or the wings of your nose. And when you do a rhinoplasty, you're going to address all three of these areas. So when you go into the specialist's office, they're going to look at you, and they're going to look at in thirds. They're going to break your nose down in thirds if they do it correctly, and decide what each third needs, and then try to figure out a plan for everything.
Yeah, and something that's really unique about the cartilage in the nose and also in the ears is that it is tensile but flexible.
Yeah.
So it's almost like, those like pop-up tents, or like the sunshades that you put in your car. You can wrap it into this tight little ball.
Which always amazes me how that goes down to that small little package, and then it kind of rolls
to a whole tent,
and it holds its memory, has that kind of memory of that tension, and it splays out.
It's very much like the cartilage of the nose. Like, it is flexible, but holds its shape even after being manipulated. So, like with your ear, I mean, can you imagine if you pushed your ear forward and then that's just it? That's how your ear was forever. Like it bounces right back.
Actually, we've talked about that in the otoplasty episode. When babies are born, they do this in Asia and definitely in Japan.
Little baby sweatbands.
No, they do, yeah, because they have.
We talk about that in the otoplasty episode. We joke about that.
The mom's estrogen is floating around, so it's like pretty high.
It's really soft,
and it makes the cartilage more malleable. And so if you put the babies in headbands for the first 2-3 weeks, then you can push the ears back a little bit. It's molding of the cartilage, but you can't do that as an adult.
That sweaty baby.
Yeah, sweaty baby.
Like that baby's so sweaty. Yeah.
With the big LeBron James headband.
Yeah, if you want to laugh, go listen to the otoplasty episode of Ty Harris talking about sweaty baby headbands.
Yeah.
But yeah, so that cartilage, even on that middle third of the nose, is kind of that same way. And that's why a lot of times we can, if somebody does have like a nose fracture, they call and say their nose is broken. Well, you can just kind of reset it by popping that cartilage back into place. In fact, last time I broke my nose, Dr. Moore was out of town, and I called him the next day. I'm like, I broke my nose. He goes, well, you know whether it's broken or not. And I knew it was. He's like, just do it. He's like, just push it back. And I'm like, I need to do this right now because it didn't hurt that bad right at that moment.
Yeah.
But I knew if I didn't do it, it was going to hurt. So like, I literally went in the room, was looking in the mirror, and I did what I've seen you do 1,000 times, and it popped right back in, and it did hurt for a long time after.
That was probably bone. I mean, was it upper third or middle third?
It was right in the middle. It hit right on the.
Yeah, it was probably still bone.
Oh man, did that hurt?
But the bone will become displaced. You can actually we call it reduce that. You do that in traumatic injuries. The middle third, which is the cartilage, it's less easy to reduce, but you can, and that can be displaced for sure with bad injuries. And Amy's right. The upper lateral and lower lateral cartilages, if you're looking on the YouTube channel, which is represented in blue, are more malleable, but they have a strength to them. Mm-hmm. So what we actually do when we take some of those out and reuse it is I take the cartilage out and I put it in this smashing metal box, and I hit it with a sledgehammer, which is very small. So I don't know what the equivalent.
It's a really tiny hammer.
A tiny sledgehammer, but it looks like a miniaturized sledgehammer.
Is what they call that.
A mallet, yeah.
Mallet.
And
sounds so much nicer.
Again, I know all the surgical names. I'm trying to figure out layperson names, so I'm sorry. Anyways, and what that does is takes out the memory, the shape memory, the three-dimensional memory of it, and then you can onlay those cartilage as grafts. But the septum itself, the cartilage is in the middle, the temple that holds up the tent. And Amy used that analogy. In all of our previous episodes, we talked about the tent, and the airways go on each side of that temple is stronger. That's harder for that to be fractured, and that cartilage is thicker and has more memory to it and strength for obvious reasons because it holds up your nose. And if that does get fractured, that's where you get, or injury, that's where you get these weird kind of turns of your nose and deviations of the dorsal lines, or the lines that come down that show the edges of your nasal bridge. So, the anatomy of the nose is very complicated. When you're doing these surgeries, I mentioned this on the previous episode, when you're first starting out doing these surgeries, man, you have to wrap your head around it. You almost have to stare at pictures, and that's not the way it was in my career. For me, it just came all naturally. I got to look at something. I was artistic. I could understand it spatially and artistically. The nose was kind of a trip. You had to really think about what you were doing, where you were, and where you are. After a while, you get used to it, and then it becomes natural, just like everything else. But it's definitely a learning process to that.
Well, it's really the only other surgery that we do that deals with projection that isn't like some type of reconstructive work is breast augmentation. So it's not, I think most of our surgeries, we are focused on pulling or flattening something, not projecting it or dealing with the projection, like the specific projection of something.
Three-dimensionally speaking.
Yeah.
And you have to imagine in your mind's eye, I'm closing my eyes, right now, Amy. You have to imagine in your mind's eye when you're doing these things, like what is your end result? And
how do you get there?
How do you get there? And
it's like backing up a trailer.
Okay, that's a lower level example.
But just that point of like,
I have to tell you, I grew up backing up trailers. It's very hard to do.
It's so hard. It's completely counterintuitive.
Because you have to think, you're mirrored.
Backwards.
You're mirrored. And you know what else is like that
direction.
is laparoscopic surgery.
Yes.
Like those, and that's why actually Da Vinci robots, those computerized robots, they help with laparoscopic surgery are so helpful because they take away the mirroring.
Right. Yeah.
You know what I'm saying?
That's cool.
Isn't that cool?
That's very cool.
Because when you move your right hand across, you were looking on the screen, it was coming left. And that was kind of a trip in the old days. Yeah. All right. So that's pretty good. So just in general, try to keep this easy. The upper third, the upper part of your nose is bone. The middle third is cartilage and septum, which holds up your nose. And the lower third is septum, which supports the tip of your nose, which are the alar cartilages that then extend out into the alar or the wings of your nose. All three of those areas can be addressed. The upper third can be addressed with osteotomies and something that shaves it down with a rasp. The middle third can be removed grossly with.
Like you just brush over the fact that we're gonna like literally grate down bone with a metal.
Hey man,
metal file.
You don't need to know what's really going on. You don't just need to see how the meat is made.
Yep.
The sausage. The middle third, you can remove cartilage. You can add cartilage in there and do some airway procedures. And then the lower third is interesting because you can do some suturing techniques to bring the tips together. If they're bifid, you can do a cephalic trim of the lower lateral cartilages, which is narrow the nose. You can add grafts all the time. You can do columellar strut grafts. You can do alar grafts. And then getting out into the skin, you can just do the Weir excisions, which we mentioned before. So there's so many different things on such a small little area. You know, that's what's so awesome.
And all of those things make a big difference.
Big difference. I mean, now we're even doing lip lifts, which is around the nose. So you're putting the scars inside the kind of normal anatomy of that lower nose. So yeah, it's just so remarkable. This surgery, and that's why it's hard to understand for any patient going into it, because it gets into a three-dimensional understanding of symmetry and contour that I think it goes way above people's heads.
And that's why you mentioned at the beginning that there's a lot of places you can go wrong.
Yeah.
Every place you can go wrong. So this is a really cool picture. Dr. Ryan actually did an overlay of a patient who was prepped for surgery, kind of showing where the changes were going to be made. So the area in that light green, the lime green, is where it's going to be taken down a little bit.
So if most people come in, not most, but a lot of the patients that come in, Amy, you would agree, have a bump on their nose in profile, right? That's a common thread.
Common.
Yeah.
Yep.
So they'll come in.
Or the width at the top of the nose in the upper third.
But it's usually their profile. They'll have like pictures and they can see the side view of their nose. They're like, whoa, that didn't look good. I don't like that. A lot of times that's worsened with previous trauma from sports or falling down.
Overprojected tip.
Drunken parties, whatever the injury was. We've had them all. And so
overhead bins. This is a real true story, people. The overhead bins, things do shift.
Yeah, we had a patient like that too.
Yep, airlines aren't just telling you that
no,
for no
literally
reason.
The suitcase hit her in the face.
We've had a couple, who
fell out of the bin.
Yep.
So if you think about it, you're going to improve your profile, and that profile is primarily the middle and upper part of the nose. So the upper 2/3 of the nose. As we've established before, the middle is cartilage, the upper is bone. So you're going to improve the contour of that profile by taking down the bridge of the nose to give it less of a prominence and more of a light concavity. Now,
a little swoop.
Not a heavy concavity. Think all the garish, terrible results you've ever seen in the media. I'm not talking about that. Something that has a slight depression that goes down and then, ends in your tip of your nose. And that is quintessential for most people. Now, there's obviously cultural differences, there's anatomic differences, genetic differences. So if that doesn't work with their face, you're not going to take that nose down. But in most people, it does.
Well, and sometimes that actually needs to be pulled up. People who have a very wide bridge of the nose and it's almost like flattened out, like it's too swoopy and too wide, like narrowing that in and actually pulling it up a little bit is what they need.
Yeah, and we'll talk about that. The osteotomies and infracturing can elevate that dorsum or the bridge of the nose. But before surgery, and if you're looking on our YouTube channel, you can see what it is in green. You'll see that that's what I'm planning to remove. Like I have it in my head. And I mean, some people draw it out. A lot of people do, but in me, it's more mental. And that's what I'm shooting for, is to remove what's in green, to give her that kind of result. And that's going to involve removing cartilage in the middle third of the nose, reducing the septum, the anterior portion of the septum, and also, I can't say, what am I supposed to say for the bone that sounds not gruesome?
There isn't a way.
Okay. Knock down
There you go.
the bone a little bit.
Just knock that down.
Just slightly knock it down.
Not cheese grater.
Who was the painter with Bill Monroe? Not Bill Monroe.
Bob Ross.
Bob Ross.
Yes.
Sorry. Yeah, thank you.
Yeah, just a happy little rasp.
Happy rasp. Happy reduction of the bone.
Yep. When I think of a rasp, I always think of Daria. There was an episode where they were telling like scary stories. It must have been like a Halloween episode. Yeah, I'm old. Daria was on when I was a teenager.
I have no idea what you're talking about.
And that was one of the things, like that was the weapon that this like creature in their scary story had, was a rasp, a giant rasp.
Yeah, just rasp thing. So rasp is basically kind of like sandpaper.
Like a
but
metal
with
file.
Metal. It's a metal file.
It's a
Thank
metal
you.
file.
Yeah, and you literally file down the
bone.
bone on the nose.
It's not scary at all.
Yeah, and then the one last thing with the overlay over surgery, the light blue is the lower lateral cartilages that includes the alar cartilages. And, that's what will reduce down, make smaller, and then also maybe suture together from both sides, depending on what the presentation is.
Yeah, fascinating to kind of see all that in color, like just to see how much is going on with the rhinoplasty. Yeah. So this is a really cool picture of the removal of some of those.
Yeah.
We'll explain. It's these two little blobs.
Yeah. So you'll go into surgery.
And how tiny they are.
Right, exactly. You go into surgery. It's usually done in an operating room. You can do these cases under local anesthesia, but those are few and far between. That's usually tip work. It would be really hard to do any kind of reduction of the bone or osteotomies or infracturing of the bone awake.
Yeah, we've done a little cartilage trimming.
But you can do some of these surgeries in the office. It just depends.
We'll clip it down a little.
You'll go in. It's about an hour or two long, and you definitely get anesthesia. In almost all cases, they'll put a breathing tube in. Sometimes they don't. We'll do it with sedation, but the breathing tube has the benefit of protecting the airways, especially you have a tendency to bleed after these surgeries in the back of your airway, which can cause coughing and even end up with pneumonia or something like that. So it protects the airway. But no matter what, I'll get to this picture, but no matter what, you have a stepwise process for what you're going to do. And every surgeon's different with the way they approach it, but no matter what, you're going to have an open or closed procedure, period. And then as part of that procedure, you're going to have reduction of bone, maybe. You're going to have infracturing, maybe, and we'll talk about that. You're going to have reduction of the middle third cartilage, which we've talked about many times in this podcast, or this episode. And then also you're going to have removal or contouring of the lower lateral cartilages, which is the tip. So go back to that slide real quick. This shows you the excision of the cartilage of the lower lateral of the tip itself. And it, as Amy said, which was a really good way to put it, it has substance to it, but it's kind of malleable. You can press on it and it'll keep its form and shape, but you can move it into different shapes. You can bend it on itself. It's a really good analogy of the tent, those pop-up tents.
Because it'll bounce back.
Yeah. But this is so important, this picture. If you're looking on our YouTube channel, our excision of the lower lateral cartilages was 4 millimeters or 5 millimeters at the most. And you have to preserve an edge of that lower lateral cartilage so the tip doesn't collapse or look weird. And again, 4 or 5 millimeters, just pull out a ruler and look at that. It's just so small.
Yeah, like so small that the person who had to write the left and right on here couldn't even make them as small as the sample because they're tiny.
Yeah.
Like they're really little. I mean, we're magged way in on this, but just this was such a good visual depiction of how tiny these little removals are.
And maybe we should show this in comparison to like
a tummy tuck flap,
a tummy tuck specimen,
even a facelift flap would look huge next to this. Even a bleph.
Yeah, or the Eiffel Tower. We can set it next to the Eiffel Tower so you can understand perspectives.
Yes. Yeah. This next picture is showing the planned incision. I think this is so critical to understand, and we've talked about this in some of our episodes. Our scar revision episode, we talk about why you would make a not straight incision. People probably look at this like, oh, what, like shaky hand there?
Well, it's like the Charlie Brown shirt.
Yes, it is
has
like
that
the Charlie
feeling
Brown
to
shirt,
it,
or like a heart rhythm.
Yeah, so there's like basic tenets in plastic surgery, and it's embarrassing because you just apply those everywhere. So then you only need to know like 5 things and have a pretty creative mind to do it. But one of them is a Z-plasty, breaking up a scar so it heals well. And that really looks better cosmetically and from a contour standpoint. So notching out the columellar incision, or that columella is the space between your airways that you make the incision for an open rhinoplasty, is necessary. And if you're looking at our YouTube channel, you make that incision across your columella that then extends into the nasal airway and up to the roof of your ala.
Barely see the purple on either side of the top of the nostril.
And that's how you open it up that way, and then elevate that skin and expose the lower lateral cartilages, doing an open approach. The closed
Pop the top.
Yeah, pop the top. Just like going to the mechanic, you know, just
Open up
popping
the-
it open.
open
Let's
up
go
the
look at that
trunk.
engine, but you're just looking at your cartilage. The closed approach would be inside these nasal airways. When you have this worm's eye view, they would be inside. So, you know, obviously the benefit of the closed is you don't see that scar afterwards. But Amy, how many times in my career has a patient complained about a columellar scar or
Zero.
the scar in between the nasal airways?
Yeah, it's not the natural position that like you see on someone. Even if you're shorter than a person, you don't tend to look straight up their nose.
And when you do, it's alarming.
Well, because that person, if you're shorter,
Yeah.
they're probably looking slightly down. I mean, it's rare that a person is looking up at you.
I was on a plane and the flight attendant came over and like she was just standing right above me, and I looked up and I was looking straight up her nose.
Right, that's awkward.
It was very awkward.
Right. And at that point, you're not thinking, does she have a scar there? You're like,
No, I
this is
was
weird.
like,
I'm looking up a person's
I'm
nose.
looking up her nose, and I was like, it's a little bit deviated. This is a problem.
I always joke with our post-operative patients with rhinoplasty, like, at what point in your life did you think that a bunch of people would come in a room and literally just do this to you and walk out?
Yeah.
We all just like staring right up your nose, like not even looking in your eye, like just staring up your nose and being like, oh, looks great. And then they just leave.
Yeah.
Like it's awkward.
It's very awkward.
Yeah, so you don't normally do that. This is a great picture. This is the same patient before and after surgery. And Sarah and I were talking about this photo yesterday when we did the slide. She's like, well, you know, the change there is, it's so subtle, but it's so apparent. And this patient was a previous MMA fighter, had broken their nose a number of times. So you see that you did a tiny little incision at the top of the nose to do some end fracturing to straighten it, because what you don't see in either of these pictures is just how wonky this person's nose looked when you looked at them straight. It was literally like an S when you looked at them because it had been broken so many times.
Yeah.
And then also reducing the very bulbousness of the tip. The tip was very large. And again, it's so hard to tell when you're zoomed in
Yep.
how the whole face looks.
Again, I think this episode would be really useful on YouTube because so much of this is visual. It's
Yeah.
hard to use words to describe it, but
Even the picture.
But if you look at his profile, he had a
really
really prominent tip, and I reduced that down and made something called a super tip break, or a demarcation between the bridge of your nose and your tip, and that's why it looks so much better. Also, when you do infracturing, we usually do that from the inside, which we call from like a low to high position. None of this stuff matters. Don't memorize it. But you know, the benefit of doing that is that you can do all the osteotomies from the inside. You make an incision inside the nasal airway, fracture the nasal bones from the base, almost where the nose, the base of the nose, the lower base of the nose, up to the bridge of the nose, and then you literally with your hands you push in on both sides to bring the nasal bones in, make it less wide. When people have had previous fractures and you do that maneuver, a lot of times it can be an incomplete infracturing because they have had healed fractures. It fractures in a weird way even with the osteotomy. So sometimes you make little external incisions, very small stab incisions, just to fine tune that infracturing. That's what happened here.
Yeah, that was definitely the case with this patient. It also had to have pretty extensive ENT work at the same time on the turbinates and on the air rim. If you look at the view, this one maybe shows a little better if you know what you're looking for. But I mean, these nostrils are, for as wide as this tip is, as big as this tip is, and as big as this nose is, you can barely see up this nose at all.
Yeah.
Like there was a lot going on in
Because you
there.
had way terrible deviation.
Yeah, terrible.
And you can actually see, again, on our YouTube channel, afterwards, he's kind of bruised on the nasal tip, and that's pretty common. This is a very bruisey procedure. So if you think you're doing a rhinoplasty with infracturing and you're going to be back at work the next day on Zoom, it's not happening.
Can be, but you better be ready to either
Have some
tell them a great
sunglasses.
story
Yeah.
or just fess up to your rhinoplasty.
You were assaulted in the middle of the night.
I don't know that that's going to make the people watching your Zoom feel any better
Okay.
about what they're seeing.
Got it.
I would just tell the truth at that point.
Yeah.
Yeah. So such a great example, though, of those seemingly subtle changes making such a big difference overall. All right, let's take a quick break. We're going to come back and talk some more specifics. We're also going to show before and after pictures, so stay tuned.
You got to stay tuned. It's coming.
And we're back. We're back. All right. Let's keep talking about rhinoplasty. Let's talk about who's a candidate.
Yeah.
So who's a candidate for rhinoplasty?
I kind of like how you mixed up this episode. Usually I get my boring discussion about the steps of surgery, but you're kind of going back and forth. You're making it exciting. It's kind of keeping my interest too.
Yeah, that's good. I'm glad.
So it's good. So like we showed some pictures from surgery. Now we're going to who's a candidate. I like this.
Yes. So really,
Thinking about the customers.
Generally, you're a candidate for this procedure if you're over 18, right? That's at most elective surgeries. However, in a lot of cases, we will do rhinoplasties on patients as young as 16, whether they have some congenital issues or they've had a fracture.
And congenital means you were born that way.
Yeah. Yeah. And even, just the way your nose was made. So if that's the case, once you've reached 16, your nose, as we've talked about in previous episodes, does continue to lengthen essentially as we age. The ligaments loosen and things kind of droop more. But in general, your nose is probably the size it's going to be when you're about 16.
Yeah. So if you're listening to this and you're 16-year-old and you don't like your nose, don't worry. It's not going to get worse. It's probably about where it is.
Yeah. It's also probably not going to get better.
Yeah. It's not going to get better.
It's going to be about the same.
There's no workouts that you can do to help your nose.
No. And you need to be healthy enough for surgery. Specifically with a rhinoplasty, if you have obstructive issues, airway issues, those need to be dealt with also. Like we're not going to do a rhinoplasty on you when you're like, oh yeah, I can't breathe.
Right. So you can do a rhinoplasty and an airway issue at the same time, or deal with the airway issues at the same time. But that has to be addressed. You're not just going to do a rhinoplasty and leave all these airway issues because those can be physiologically problematic.
Yeah.
So, and then, all the other stuff we talked about, smoking, not happening. So you got to stop smoking, sleep apnea, diabetes, high blood pressure. You're dealing with medical issues right now. You're on steroids for some sort of autoimmune disease. I mean, there's so many different things that would preclude you from doing surgery, unfortunately, but it is elective. It is an elective surgery. Post-traumatic rhinoplasty has a little less feel of elective, but at the same time, that's still elective, which is evidenced by the fact that most insurance companies don't cover that. So it's an elective surgery. It's something you're doing for cosmesis or contour improvement.
Yeah. If an ENT is doing something on the inside of your nose, it probably
or plastic surgeon. Plastic surgeons do it too.
Well, no, just that it might not change the outward appearance.
Yeah.
So cases that are covered by insurance are usually things that are working on the internal structure only and don't have a cosmetic benefit.
So there's like when a plastic surgeon or ENT does septal work on you because your septum is deviated or curved, that can have a positive effect on straightening your nose for sure. So that is the true benefit of airway surgery, is that it can straighten your septum and make a difference, Yeah,
but for most people who seek a rhinoplasty, that's a minor part of the issues that they're dealing with. But yeah, absolutely.
Yeah.
And you've seen people, hockey players, a lot of people have noses that just have a little weird little turn in the middle. That can be fixed with septoplasty. All right, let's talk about downtime and recovery. This is the most common question for really any surgery. When can I be back to work? When can I be back to fill in the blank? You can definitely expect, as Dr. Martin mentioned on that previous picture, several weeks of bruising and swelling. The swelling is very patient dependent. If you have a splint over your nose, a little nose cast, it's going to force all the swelling into the tip, which I love when we do a tip rhinoplasty on somebody and they're like, oh my gosh, it's bigger than it was before because it's so swollen. And then this little splint is trapping it all down. So don't let that freak you out. You'll be bruised, you'll be swollen for a couple of weeks, and you'll definitely have difficulty breathing through your nose. If anybody who's had an infant, the first time they get a cold and oh my goodness, like you feel so bad and they can't, because they are not mouth breathers. So as soon as they can't breathe through their nose, they just scream, and it's like, it's not good. And I tape my mouth shut at night. So I am definitely a nose breather. So this would be very challenging for me, just that feeling of being very congested and needing to breathe through your mouth. Also, your nose is going to run a lot. I told a patient yesterday who was scheduling a rhinoplasty, I'm like, be ready for it to just be very drippy for a couple of weeks. You can't blow it. Can't really do anything about it. Just have a Kleenex kind of nearby. So it's annoying. Exactly. And that's what I said to her. I'm like, of all things, it's just kind of annoying recovery. It's not like it's super painful. No exercises or anything that's going to cause you to need to be breathing heavily for 4 to 6 weeks for very obvious reasons. If you can't really breathe through your nose well and you're dealing with a lot of bruising and swelling, you don't want to be trying to breathe heavy right away. And just the blood flow issues, as we've discussed in a lot of our podcasts. This one I love. People are like, what? Like you cannot do any impact or potential impact activities or exercise for 6 months.
And that's especially true if you have infracturing or they deal with the bones. It maybe is less true for the cartilage work, but still you can disrupt everything we're doing. It's so minute. Even those sutures that I put in there are 6-0 sutures, and that may not mean much to you, but that's probably thinner than a human hair almost, So, you could disrupt everything we do. One
pickleball to the face.
Right. So you really have to be motivated after these surgeries. This gets hard on young people that have had previous traumatic injuries and like, they're into sports, they're young. It's 18, 19 years old, oh, I can't wait to do this. And you're like, oh, I'm sorry, you just have to be responsible here.
Yeah,
it
swimming
is
is actually a big one, like diving into a pool.
There you go with swimming again.
Yep.
I feel like
you're going to just wade in nice and slow.
There you go, swim. Yeah. When do we get the sutures out, Amy?
So we'll do suture removal 7 to 10 days. A lot of the, those sutures are internal and those dissolve over several weeks. They're a quick dissolving kind of suture that dissolves in that kind of moist but aerated environment. The same ones we use like in the mouth or in the nose. They're kind of clear. So it's weird. I always tell people to be ready for that to maybe fall out at an unusual time. Don't let that freak you out. Parts of your nose are not falling out. That is suture material, but it is kind of this weird clear beigey color.
It's more beige. Yeah, it's almost like
it's like translucent beige,
like a lighter skin color. Yeah.
Yep. Recovery is rarely painful. Like it's very rare that someone is complaining of pain after the surgery, but is uncomfortable, especially for the first couple of weeks.
Not breathing, swollen.
And I could tell you this from having a broken nose. Like, it does hurt if you like touch it, or even if shower water hits it. But the rest of the time, you're feeling pretty good. Just don't have your head below your heart or get your heart rate up, and it feels fine. If you start having blood pounding in your face, it's going to hurt a lot. Icing and over-the-counter medications help decrease the postoperative discomfort. It's rare that a patient even really takes prescription pain med after like the first day or two. It's just not that painful.
That's heresy, Amy. What are you talking about? Opioids solve all of our problems.
I think they can. What has the last few years shown us that they actually cause a lot of problems.
Yeah, they really do.
But it's really.
I can see opioids for a couple days, but you got to get off of them quick.
Yeah, maybe 2 at the most. I mean, as long as you're not touching it or doing things you shouldn't be doing, it shouldn't be hurting. I mean, it's going to be sore, but.
And fracturing definitely hurts more. So if you have the bone work, then you probably would have pain longer than not.
Yeah, but over the counter, I mean, Tylenol, icing, both those things are going to really help a lot. So just being ready for the difficulty with breathing, needing to sleep on your back at a slight elevation, some of those things that are inconvenient after surgery, not being able to swim or dive from the high dive for a few weeks, months. I think we need to make a pact, Dr. Rhino. For every time I bring up swimming,
I'm going to bring up the V word.
There you go.
Yeah.
Yep. Fair.
Yeah, fair.
Deal.
Let's deal. Okay, let's do it. We got it.
Okay, we got this, Nils. All right. So downtime recovery.
I'm actually not even against swimming, to be honest with you. It's brought up so often.
People ask all the time.
I feel like they don't. I feel like this is a self-fulfilling prophecy. You put it out on this podcast. Everyone watches the podcast. They come in and they troll me about swimming questions.
I actually was thinking about this the other day, mostly because I know how much you hate me talking about swimming. You guys had a membership to a swim club.
Yeah, we had kids. That's what kids do.
Yeah, right. So what do you think
Diving
our patients
boards
have?
And swimming. I know.
Yeah, that's why.
Yeah, but I never really got in the water either. I don't know.
We had a patient a few weeks. Actually, this was just last week. She had a mastopexy aug, which is or breast lift with breast augmentation, and she was right at like the 4-week mark. And she goes, "We're going to a hotel this weekend, and you just wonder if she'd get in the pool." And see, even then.
I have a funny swimming story. So I always consider myself a strong swimmer. Okay. And if you swim, you usually swim in a pool, right? So you go and good swimmers.
Like to do laps.
Good swimmers will go back and forth, but I'll maybe do 1 or 2 laps, stop, and 1 or 2 laps. So obviously I have to improve my endurance, but I was in the ocean and swam. After about 2 minutes, I was had to go full on backstroke. I was so out of breath because obviously my cadence of breathing was not that great. And then the waves were coming over. Oh my God. I was in a terrible shape. My heart rate was super high. I'm in pretty good shape. I do a lot of cardio. Man, it was hilarious. It was very humbling.
Ocean swimming is really hard.
It was very humbling. You could see how people get caught in underdraft. So.
Oh yeah. Especially people who are not good swimmers and or a bit out of shape. Like the ocean is a dangerous
Fortunately,
place.
I was with someone who is not as good shape as me. So
they were going to be
hey man, that's okay. I'll go backstroke with you. I play it off.
Yeah. We'll just float our way back in. Yeah. We're good. Yeah. We're going to get ocean rescue out here any second now. All right, let's look at before and after pictures.
Real quick. So I did, and again, this is getting into the weeds, but I think this is very important. So when you do a rhinoplasty, there's usually steps. Okay, these are my steps. Just FYI, open or closed. I treat the dorsum or the profile of the nose first. Okay, so I'll reduce the bone and I'll reduce the cartilage in the middle part of the nose to make the profile better. That's first part of the surgery. And obviously there's local anesthesia injected in there. The second part of the surgery would be the infracturing of the nose, because you have something called an open roof deformity. You can look that up. It's it's important.
When you see it, it's real
Yeah.
weird.
So if you take down a lot of your profile of your nose, the dorsum, which is the medical word, then you get left with a deformity that you need to close, and you close that by doing the infracturing and pushing the bones in. So the bones are normally open. If you're watching on the YouTube channel, you just look at me, and then they come in like this. So that's dealing with an open roof deformity. And the third thing I usually deal with is the tip of the nose last, right? Once I get that profile good, then I can work on the tip of the nose, taking off the lower lateral cartilages, adding cartilage, doing tip grafts, doing columellar or strut grafts, anything you name it, we can do. And we didn't talk about spreader grafts too, which are on the inside, which help with airways, but can also improve the dorsal lines or the way that the bridge of the nose looks like front to back. Sorry, go ahead.
No, that's perfect. It's rare that we do have someone that has too narrow of a nose. It tends to be but it happens.
It happens, and the spreader grafts
Yeah.
do make a difference there.
Yeah, the open roof deformity, we had a patient years and years ago who had previous rhinoplasties and had an open roof deformity, and it was actually the first time I'd ever really seen it that badly. I mean, if you think of what a or a soft spot on a newborn's head looks like where there's literally no bone there and
Like
there's
the fontanelle.
like a depression.
Yeah.
Yeah, very, very unusual. Yep, so there are a lot of, like we mentioned in one of the very first slides, things on the nose that are odd or fine, but that are weird are real weird.
Yeah, I mean, especially you can get in these very nuanced procedures with rhinoplasties. Like some people of African descent or severe trauma have nothing on the profile of the nose, minimal there.
Flat.
And so you'll use a rib graft, actually, cartilage from the rib, or you'll use implants to build up the bridge of your nose to make it look more better contoured and have some sort of shape to it in profile.
Yeah.
So there's so many different, I mean, with this podcast, this episode could be a couple hours long just talking about the different surgeries.
That's why we were on for the third episode about rhinoplasty.
Yeah.
We still have lots to talk about.
So anyways.
Yeah. So let's look at some before and after pictures.
By the way, the only book I read anymore is the Rhinoplasty book, and I still get little pearls from that, which is so interesting. And I think I read it just because I enjoy it. It's just so complicated.
Yeah. It's like reading your favorite cookbook.
Yeah.
There's always something else to find. Yeah. So this first picture, this was actually the drawing from the beginning, kind of showing what was done here with this surgery. So
yeah, and this is on our website. I think this was on the previous episode, but I think it's a good picture because it's basic and normal, right? And I like things that show people real results. There's nothing super special about this. Right in the middle, this is like a majority of people.
yeah, she kind of needed a little bit of everything.
Right.
A little bit of
looking
shaving
at this,
down.
if you're not looking at this, I'll explain it. We have a picture of the patient preoperatively in profile. She has a prominent profile or a prominent nasal bridge. And then she doesn't have a lot of definition between the nasal bridge and the tip of her nose. The tip of her nose is slightly protruding downward. She doesn't have a great angle between the tip of her nose and her lip. And it's just really kind of an ill-defined nose. It doesn't have a lot of nice shape to it. It feels almost hooked a little bit. It has kind of a curvature that goes down.
Yeah, a little droopy.
So what we did, and when you go in for your consult, you can say to the surgeon that you're meeting with that, let's talk about the different thirds of my nose, because this is what Dr. Martin told me to talk about. And the doctor will probably be like, what are you talking about? Why are you saying these words to me? But, if you think about for this patient, the upper third, which is the bone, we're going to have to rasp that down. What is the nice word we said for rasp? We didn't come up with a new word.
Knock that down.
Yeah.
Just
yeah,
knock
Bob
that down.
Ross. We're just going to slightly bring that down.
Bring that down.
For the middle third, we're going to take some cartilage out of the upper lateral cartilages and the septum itself, and we're going to do that in composite fashion. And then the lower third, we're going to do a cephalic trim of the lower lateral cartilages, or take, if you're looking at the picture, the blue cartilage that's down below, take some of that cartilage out, and we're going to sew those two prominences on that lower cartilage together in the midline. She does not need a columellar strut or something to support the tip of the nose, and that's all she needs, and that's what we did. Now, we didn't give her a really strong super tip rake because she didn't want that. She just wanted the bump down enough to where it's almost even with the tip of her nose, but we gave her a little bit of a transition to the tip of her nose, which was enough to make a big difference.
Yeah, and get rid of the little bit of droopiness. And
Yep.
there's just that picture a little bit closer in so you can see it a little bit
If you're
better
looking on the
without
YouTube channel, it's a picture again of her before and after closer. You can see that the angle between the tip and the lip is better. You can see that her tip is more defined and refined. The bridge of her nose, we probably took a couple millimeters off. And even her nasion, or the area of bone between her eyes, looks better.
Yeah, really awesome result. She was very, very pleased. So this one is a immediate before and after, meaning if this was a picture taken with the markings on before surgery, and then literally while the patient was still asleep.
Yeah, so again, if you're looking at our YouTube channel, you can see they're a little bit bruised afterwards. They have a little bit of blood coming out from that columellar incision.
And this was the one, if you are watching in the beginning, where Dr. Ryan had the green strip at the top.
Yeah.
This is that patient after surgery.
Yeah, and so somewhat similar. You can really see, if you look at the tip of her nose in the pre-picture, where her cartilage that defines her tip is really prominent.
Yeah, it was so thick.
And it's like high and kind of sticks out, and you can actually see in the after how much better that is. So that lower lateral cartilage was definitely improved, and overall just a better result, a better contour for the patient.
Mm-hmm.
Yeah,
she was really pleased. This was a really young lady. She was really pleased.
By the way, if you're looking at the pre-picture, you have these little black dots that are on the side of the nose. That is the area where I do the infracturing. So you do the osteotomies or break the nose there. You can do that externally with a small stab incision like you saw on that previous picture, or you can do that internally with an incision inside the nasal airway.
Yeah, and you do see also there is some immediate bruising. We're not trying to hide anything from anybody. Right away, even before she's awake, there is already a little bit of bruising in the settling in.
I think I've made all these jokes before, but like on the reality shows, they do the after, and they're like, "Oh, look, it's only a week," and it's like such
6
BS.
months. Yeah,
it's like 4 weeks or 5 weeks afterwards, and they save the little cast. Let's just put this on, and then we'll take that off, and you can look at it and be so surprised. Yeah.
Well, but to be fair, I mean, when you take that splint off, you can see an immediate difference.
Of course
it's
you
just
can.
not like
it's remarkable, and all patients are really happy. But some of those reality shows, which I don't, for that reason, I don't really watch them, aren't really that real. Yeah, unfortunately.
You mean there's no reality in reality TV?
No.
Who knew?
Who
knew? All right, here's another one. This is great. I think something that I always say with before and after pictures is you don't know the size of this person. And this patient is super tiny. Mm-hmm. She's like 5'1", weighs like 90 pounds soaking wet. And her nose, as you can see, definitely had a very prominent bump and had a pretty large tip for the size of her as a human.
Yeah, and you got to consider people and their backgrounds, their appearance, their anatomy, their genetics, their culture, et cetera, et cetera. And she was someone who was more amenable to a little bit of the shortening of the nose, narrowing of the nose, taking down the bump, really improving those contour lines that emanate from her eyebrow and go down to her tip of the nose, that really having a nice flow of the bridge of the nose going down to the tip, which is a lot more refined. And maybe I wouldn't make as refined on other types of people, but this really worked for her.
She's so petite.
Yep. The tip of the nose goes up a little bit. And this is definitely more of an involved rhinoplasty, a little bit more manipulated, but it really does work for her and her face. So, again, you can leave some elements of someone's nose that maybe aren't as quote unquote desirable, but that kind of work with their face. I think this was like an overall rhinoplasty that affected the upper, middle, and lower third with a very nice result. And it's very additive to her overall facial beauty, of which she was, very pretty beforehand. And now I think this is additive to her look or the way she appears.
Absolutely. And you mentioned this on the last patient as well. Like there's just the kind of the balance between the eyes and the bridge of the nose, and also the lips and the nose. I mean, in the pre-picture, her lips look really tiny. And like I said, she is very petite, but they look so little because her nose was quite large. And then in the after, they look very balanced.
Right.
Like the nose and the mouth look of the appropriate like petiteness to each other. And the eyes almost look wider and like a little bit, we talked about the Nautilus, the perfect set, the balance, it kind of just gives those dimensions.
The Fibonacci sequence.
Yeah. Kind of changes those millimeter dimensions a little bit to make the eyes look wider.
I was talking to a patient and I brought up the Fibonacci sequence and she looked at me like, what are you talking about? I was like, never mind. Never mind.
Yes.
Well, sometimes I get lost in my artistic thoughts and discussions, and the patients are like, "Can you please stop with this artistic talk? Can we just talk about the surgery real quick?"
Or they join in. It's one or the other. We have some pretty awesome patients.
But also on this, we did an open on her, I think, or close to. We did an open, and you can barely see the scar. It's just not visible.
Yeah, it's really, with all these patients, it's completely hidden. So here's a really zoomed in one, but this one is really cool to show really what an impact that.
It's kind of a spooky picture.
It is. Well, because it's kind of, Sarah tried to play with the colors a little bit, but they're so closed in, it's a little overexposed.
Yeah.
And I also had her flip it because it was facing the other direction. Since all the other noses were facing right, I'm like, no, we can't have the last one face left.
Yeah.
Like that messes with my mind. So
I mean, this is like a good example of just the profile alone.
yes, and I think what needs to be done to kind of pull that tip up a little at the same time.
A lot of people they have long noses and prominent profiles. The bridge of the nose is prominent. They usually have, or a lot of times they'll have kind of more of a droopy tip. And so lifting that tip a little bit, and this is very subtle in her, as opposed to the last picture, which the tip was lifted a lot more than this, kind of really works with her. It's very interesting you guys did the before and after layered like that.
You did that.
I did?
This was the way you sent it. You just had it facing the other direction.
Oh, that weirds me out. Okay.
Yep. No, this was directly from you.
It was?
You did this. Yeah. Yeah. Cool, right?
What wizardry is this?
I know, it's kind of cool.
Are you guys messing with me?
Yeah, no, you did this. Sarah and I did not do this. But yeah, the balance of the face, I think, is so important. And that's why rhinoplasties can go wrong.
Yeah.
Because when you change that from being, quirky, like I said in the beginning, to being weird, you notice. And even if somebody doesn't really know what's off when they look at you and something is weird, or if genetically you have this big hook on your nose, like people notice that too.
Yeah,
Owen Wilson.
Yeah. I think that
our biggest fan.
I think the big part, if like you were talking about the surgeon, is to have some self-control. Mm-hmm. Number 2 is to have some aesthetic vision. That's the hard part. So the hidden truth of plastic surgery, and you could say this about facial plastics, they act like it doesn't matter for them, but it does for them too, is that you have to have some artistic vision, right? If you can't go to an architect who's purely algorithmic, at some point the architect has to look at that box that you live in to make it better. And they have to have visual or mental ways of working through that, right? You just can't go to a cookbook and say, well, the house is 3,000 square feet. I want to add on something on the back. You put this kind of thing off the back. So surgery has that quality, but when you get into these small 3-dimensional areas that are complicated, you really need to have someone who has vision, but also self-control. And that's the main thing. And you learn that. When you first start out, you have self-control because you're so freaked out that you're going to mess it up. But when you get good at this stuff, then you have self-control because you know where you can push it or not push it. And we do a lot of rhinoplasties. Primarily, they're people post-traumatic or primary rhinoplasties, sometimes secondary rhinoplasties. I have colleagues that I really respect that do tertiary rhinoplasties. Those rhinoplasties of people that are really, really messed up. And that's a whole subspecialty in itself because that takes some really outside the box thinking. They're almost always very technically talented surgeons, and they're doing kind of nutty procedures, right? So it has to have their certain mindset. Yeah.
And we talked a lot about rhinoplasty in our episode a long time ago about whether or not plastic surgery makes you happy, because rates of unhappiness with any plastic surgery procedure are highest in male rhinoplasty patients over the age of 40. So it is definitely a surgery.
Nils can't have his rhinoplasty that he wants.
Well, it's not that. It's more that people put a lot of emphasis on things, and the nose tends to be one that gets it. It's kind of like cellulite. Like when someone has zeroed in on it, like that's all they think about. The difference is with rhinoplasty is you literally see your nose every time you look in the mirror, or any type of reflection. So you can fixate on it a lot. And when they go wrong, we all know, like they go terribly wrong in some cases, but people get really afraid for that reason. I think it's completely unfounded. I mean, well-done rhinoplasties, as you've seen on noses of very different types and very different people and very different sizes, and men and women, like can look just beautiful and subtle, and no one would ever know. Have we ever had a patient who has told us, wow, someone noticed my rhinoplasty?
No.
Even when it's pretty drastic.
Yeah.
Like the change is really major.
And that's the weird part. So having some sense like to ground yourself as a surgeon, and then to really take in who the person you're operating on is, their anatomy, their background, their personality, and really trying to formulate a plan that fits with that, I think is extremely important. Again, that sounds sort of meta and emo, but
not when you're talking about the face.
It is. And if you think about it, if you do a perfect rhinoplasty, but it doesn't fit the person's face, think Jennifer Grey from Dirty Dancing. I mean, does anyone even know her anymore?
I'm sure people do.
Okay.
But yeah, I mean, people thought
that's
that
a perfect example. She had a really
her.
good rhinoplasty, but just made her look so much different. That could have been done with a lot more subtlety, and the outcome probably would have been better for her. No, I'm sure she doesn't regret it. I'm sure she's had a great life.
Well, she's talked a lot about it, though. It definitely did change things for her.
I'm not trying to surgery shame Jennifer Grey, but It bums you out. So, and that's the thing. There are people that come in our office that don't agree, like patients that want something drastically different, and that's fine, but that's not what a good rhinoplasty is, at least in our office and for most people.
Well, it's the same thing with any surgery, though. There are people who want garish, huge implants. There are people who want things we can't do, not to be able to lift their arms up over their head with a backplasty so tight they can't put shirts on. Like, because people want a lot of things.
If the fellows were here and I was teaching them, which we had the fellows that come through from the university, I would tell them, hey, red flag. If someone comes in and wants a drastically different nose, you need to take a step back.
Or is having like their third or fourth or fifth revision of their
even
rhinoplasty.
more emphasis on that, right? Because that patient's not going to be happy. And I'm not blaming the patient for feeling that way. I'm just saying that there are some things that haven't been worked through. Maybe the previous surgeries were so traumatic. I mean, that's unfortunate, and I feel for those people that they have such bad feelings inside.
Well,
they want
or they've
everything
been
different.
promised so many things.
Right. So subtleties is better, nuance is better, a formulated plan, and at least some artistic vision on what you want to do. But
see if your surgeon can do what Dr. Martin did with the nose drawings.
I don't know if the drawings make a difference, but
I think they do. I'd feel better about knowing that somebody could actually do that. Like, okay, cool. Like,
So as a sales pitch, maybe I'll just be one of those cartoon caricature people. When people come in, you'll do a consult with me, and I'll sketch you out as a cartoon character. I can do that.
Can you imagine how awesome that would be?
I can actually
sign
do that.
it.
I'm not joking.
He's taking notes, and then at the end, you just hand him a piece of paper with a caricature of themselves on it.
And the cost of the surgery I'm recommending.
Oh my gosh! If you did that on all my, you should do that on my quotes. That's it. You have set us apart.
Yeah.
Like,
I'm not sure I'm going to go to him, but look at this cartoon character.
Right. See, that'll be the thing. Like, we talked about the patient who had the doctor's office who slid the piece of paper across to them, like, some type of weird bank negotiation.
It was like an illegal negotiation.
Like, here you go.
It was actually written on legal paper.
Yeah.
And then it was turned around and pushed across the table toward them.
So what I will do is, like, I will show them their quote and then say, did you see this?
And on the other side will be my sketch of you as a cartoon.
And then I'll flip it back over and be like, right with them with a big ice cream cone. Yeah.
Or a wizard hat.
Yeah. Flip it over and be like, would you like to schedule now?
Yeah.
Oh my gosh. Well, you kind of did. You've drawn pictures of me and Nils, and they are awesome. I love them.
Oh yeah, I did draw pictures. Yeah. That's your screensaver. It was.
Yeah,
man. It's like my little.
Yeah. I love it. It's the best thing ever.
So rhinoplasties are awesome. If you're a candidate for one, you're lucky because they're great surgeries. They're truly transformative. There are experts that do this. They're both plastic surgeons and facial plastic surgeons. I absolutely think both of them can do it well. So don't believe the hype if they say one is better than the other.
And ENTs, throw them in there.
Well, facial plastic surgeons, ENT. Sometimes OMF surgeons will do it, but it's mostly ENTs and plastic surgeons. Make sure they're board certified. Make sure they do this surgery on a regular basis. Look at their before and afters. And then when you go in there, make sure you remember upper third, middle third, lower third. Upper third, middle third, lower third. That's the areas that they need to look at to see what you need changed. Also know that if you have bone work done, you're going to have a lot of swelling and some bruising. That's going to increase your recovery. But overall, the recovery, even with bone work, is 1 to 2 weeks at the most. It's not super painful. It is annoying. You do swell. You can't blow your nose. You got drippy stuff coming out of your nose. You're going to have a cast thing on your nose.
Splint. Your
tip is going to be swollen and phimotic, looking like Bill Clinton. It's not a great recovery in that sense, and you could have black eyes. So
it's definitely one where the social downtime is high.
Yeah. You can't hide it.
No, you can't hide it.
At least, yeah.
Dark glasses can hide some of the bruising, but they can't hide the rest.
Yeah, you could do that digital underground glasses that covers the nose too. Yeah. Yeah. Anyways, but it is an amazing surgery. The one last thing we did not mention, we've mentioned it in previous episodes on rhinoplasty, is that you will have swelling for a while.
We did talk about that.
Yeah. Did we talk about that here?
Wish we did. In our Downtime and Recovery slide, we did talk about that.
Oh, yeah. So that is something that kind of unnerves people. Like by 4 weeks, you're going to look pretty good, but you're not going to have the end result. And your nose may still be swollen and look big. So and for people that have big noses that want smaller noses, that can be a little disconcerting. So, but it is an awesome surgery. It's one of the favorite surgeries we do in our office. Amy and I both love it. And it's only a couple hours.
Yeah,
so it's quick.
It's quick, but the social downtime is long. I feel like we need to make like a Schoolhouse Rock. We need to make surgery rock videos. AI needs to do that for us too. So like instead of like conjunction, junction, what's your function? It would be like nasal function, what's your third. I don't know. Nils understands. All right. Well, before I go too deep into the AI rabbit hole, we'll just finish off this episode here. So if you've made it this far, we really appreciate you listening. We'd love it if you would recommend us to your friends. If anyone you know is considering rhinoplasty, share this episode. Help them out. Help them not be afraid. Rhinoplasties are super awesome.
Don't be afraid.
You can also find all of our social medias right here. You can leave me a voicemail if you're so inclined at 303-630-9038.
Don't waste your time. She's not worth it.
Send me a text. I mean, if the universe has told me one thing in this amount of life that I've lived, that is exactly what it is, what you just said. So thank you all so much for listening.
Pity party, please.
And we will...
I'm here every week with you. You're worth it to me.
There we go.
But I'm not leaving you voicemails.
Worth it to me.
Yeah. No one leaves voicemails anymore. No one does.
You don't.
My kids laugh at me that I put emojis in my texts. I mean, they're like, "Oh my God, what are you doing?"
That's because you overuse emojis.
I do.
You've gotten better.
One per paragraph.
Which is, you've gotten a lot better.
Okay.
You used to overuse emojis.
And now
now
I've condensed it down to 4 of them: the finger that goes straight up, the fist, and the heart. Yeah, and the arm.
Oh
too.
yeah, we pulley.
We did biceps.
We pulley a lot. We
do that one. That's
pulley.
my 4. They get rid of all the rest.
There you go.
Yeah.
Besides the country flags.
You're the
Like,
one-
where are you? I'd like to send the country flag.
No, I've never needed that one. The one I use the most is
Yeah.
and.
Yeah. That one too. Okay.
Okay. All right. Well, let's let everyone get on with their lives. Thank you so much for listening, and we will see you here next time.
See you next time.